Lack of statistical skills is another common barrier to evidence-based physiotherapy. In this video, 3 clinician researchers tackle the barrier of interpreting comparative effects in trials.
When we're interested in estimating the benefits or harms of our common treatments, it's really important that we also consider that these are always comparative effects, which means there's always an intervention that we're interested in and a comparison group. The tricky thing is we can measure 2 different types of effects here. We can measure the change within group, or we can look at the difference between groups. And both have a role, but actually it's the difference between groups which is the most relevant when we're considering benefits and harms, because it partitions out all those other effects associated with receiving care, which get muddled up within that change within group.
I think it's good to acknowledge that the within group difference does measure the treatment effect. That is part of what it measures, but it measures learning effect, placebo effect, regression to the mean, a whole lot of other things as well. And so you can't find, even though part of what you're measuring is the treatment effect, you can't find it, because I think most people hear that and they think, but it is in there. Like someone's had a baseline measure, they've been treated and they've changed, and now we've remeasured them. Surely that is measuring the treatment effect. And I think it's good to acknowledge that it is. But because it's also influenced by a whole lot of other things, you can't tease out what that treatment effect estimate is from the within group difference.
So really we're interested in the difference between groups. And when we're talking about difference, we also need to know about what the group is. So what is that group we're compared to when we're interpreting that difference? Yeah,
that's a good point. The choice of comparison groups will have a big influence on the interpretation of the size of the effect and whether the comparison was a fair test of the treatment. For example, if you compare to no intervention, then you'll get an estimate of what the treatment effect is. But if you were to compare to harmful control intervention, then you would exaggerate the treatment effect. You also need to think about the experimental intervention that's being delivered. If you were to deliver it in such a weak dosage that it wouldn't really affect the patient's outcomes, then it's not really a fair test of the intervention again. So a lot of thought needs to go into what treatments are going to be compared and what question you're answering. If you compare to no intervention, then you get the physical effects of the treatment, but also the effects of giving attention and time and concern to the patient, and that may influence their clinical condition. If you have a control condition that maybe spends equal amount of time with the patient but doesn't deliver the active therapy, then what you're really measuring is what's the active component of the treatment, and you've controlled for just what might be attention effects of spending time with the clinician. So we need to think a lot about the comparator. We need to think about it as researchers, and we need to think about it as readers of research.
That's really interesting, Mark. So what would the ideal comparators be as clinicians when we're reading research? What should we be paying attention to?
Well, it's not a straightforward question. There's a whole range of studies from effectiveness through to efficacy. So are we testing this condition under perfectly controlled conditions where we're just trying to see, do we get a signal out of this intervention in measuring the outcome, through to if we apply this treatment in a real world situation, what do we find, where patients may not be compliant and conditions may not be perfectly controlled. And so I think as clinicians, you should be more interested in the real world, the pragmatic research. So that's one thing to consider. Another thing you should consider as a clinician is the treatment being compared to placebo or sham or no intervention, in which case it's telling you how much better is this treatment than doing nothing. But what is often more relevant to you as a clinician may be compared to what our current best management is this treatment a better alternative, or does adding this treatment to that current best management make any improvement in the patient's outcomes, or are we getting the best outcomes we can get with the current best care? And so you need to think carefully about what's the active intervention, what's it being compared to, what is the contrast between the two groups, and then that tells you exactly what question you're answering. What is the effect of this therapy? Is this therapy worth adding to usual care, or is this a better alternative compared to usual care?
I think that's very much how I think clinically when I'm working with the patient, because they're already there in front of me receiving care, and the decision I need to make is, of all of the interventions I could choose, which I should prioritise or which I should definitely deliver. Maybe I should say the decision we need to make together. Sometimes that's hard in neuro. The decision we need to make together is which intervention we should prioritise or choose over the many possible that we could pick from.
The one thing I would note is that sometimes, well, quite often we see usual care used as a comparator. And that makes sense because we're trying to integrate these interventions into usual care. But often that intervention itself is not well described in the research, in the paper that you're reading. And sometimes it can be made up of outdated treatments which actually aren't recommended and possibly can be harmful. So I think it's just worth having a caveat when you're reading a paper which compares to a usual care intervention, to pay close attention to what was provided, if reported. And maybe a better alternative to usual care could be a comparator, which is guideline-based care. So then you actually are looking at the intervention you might be interested in, compared to one which is an endorsed intervention, which actually has some sort of therapeutic benefit to the participants.
Yeah, that's such a crucial point. And I see that so often in manuscripts that come into the journal, is that people just say, oh, well, the control group got usual care. And I think, well, usual care is different between Brisbane and Brazil, and we need to know exactly what you did with your patients. So you need to have some sort of description of usual care, and guideline-based care is a really sensible way of summarising that, and probably using something in usual care that should be being used as usual care at the moment.
What about no intervention usual care? Do you compare your active intervention versus nothing, understanding that there is some of the effect you're going to find is just because you're offering something?
Yeah, I don't have a problem with it. I mean, if part of our treatment is due to contact with the clinician and attention from the clinician, there's no way we can deliver that treatment without it and without the contact of the clinician. And so if that's all part of the treatment, then I think it's valid to measure that. I don't have a problem with those trials. If there is a treatment that has very poor physiological rationale for why it should work, and it looks as though it could all be due to placebo effects or attention effect, and people have great concerns about that, then I think it's appropriate to then go on and do a study where you do have an attention control and say, well, yes, we definitely see improvements in the patient's clinical condition when we use this therapy in a no intervention controlled trial, but let's now do one with an attention control to see how much of that benefit that we observed is due to the actual physical intervention and how much is due just to contact with the clinician.
There are some very smart attention control trials out there. I always think the first one I read was Kath Dean's reaching and sitting work, where one group got reaching and sitting to actually practice and challenge their ability to sit, and one group did equivalent cognitive tasks in sitting that didn't challenge their sitting at all, actually challenged their cognition. And I always remember that when I'm reading any other research, because I think what a great way of giving an attention control that was similar but not the same, aim of the intervention.
We have to, I think, accept that there's probably no perfect sham or perfect placebo in the sense of being completely inert and having no effect on anything. But we just have to accept that we look at what was done and we think, oh, okay, well, that probably didn't have a substantial influence on the sort of outcomes that we're interested in. So we accept that it's an acceptable sham. But yeah, that's a good point that you made about Kath's study.
I think it really touches on the idea of choosing a comparator for your research question, and your research question is heavily tangled into what parts of the intervention you want to control for, so you know what effect you're trying to estimate. So yeah, if you really want to just estimate the active component of that part of reaching and sitting, that makes complete sense to want to then control for all those other features of care, being in the chair, being with a therapist, coming into a clinical trial. But if all you really want to know is what is the effect of doing this compared to doing nothing, then that no treatment option sounds suitable for that research question.
Another time that comes up, what the comparator is, comes up as a crucial issue is in systematic reviews. For example, if you were running a systematic review looking at what's the effect of inspiratory muscle training in stroke, there are certain trials that you could put in and other trials that you couldn't put in depending what the comparator is. So inspiratory muscle training could be compared to no intervention, could be compared to sham IMT. You could have inspiratory muscle training plus usual care or guideline directed care versus guideline directed care only. You could have inspiratory muscle training plus education versus education only. In all those trials, the experimental group is getting inspiratory muscle training where the control group isn't. And so the contrast between the groups is inspiratory muscle training. And so those trials, it makes sense to pool trials where that is the contrast. What's different in what the groups got was that the experimental group got inspiratory muscle training and the control group didn't. Unfortunately, I receive a lot of systematic reviews where, mixed in with those sort of more pure comparisons, you would get other trials such as inspiratory muscle training versus education, or inspiratory muscle training plus education versus usual care. And then in those sort of examples, you can't tease out what is the effect of inspiratory muscle training. You can't isolate it. And so then that sullies the whole meta-analysis, because some of the trials are answering the question you want and some of them are not. And when you pool all those answers, how do you interpret that? It becomes uninterpretable.
I totally agree. It's really hard to make sense of those confused effects when you mix comparison groups, particularly as we talked earlier, that when we're comparing against a sham or compared to another active intervention, we're comparing or isolating different parts of the intervention itself, and we're likely to see different effects. So we really need to make sure in our normal trials, but also in our reviews, that we have consistent comparisons for those pooled effects.
This campaign is supported by World Physiotherapy and physiotherapy organisations in Australia, Italy, France and the Netherlands. Please join us in the PEDro Tackles Barriers to Evidence-Based Physiotherapy campaign and help tackle the biggest barriers to evidence-based physiotherapy. You can follow the campaign on the PEDro webpage, blog or social media.